asked Dr. Bardia to explain the significance of an ESR1 mutation.
The key point regarding ESR1 mutation is that it's acquired. So when a tumor is inhibited by an aromatase inhibitors lower estrogen. The tumors can become resistant to aromatase inhibitor by developing a mutation in the estrogen receptor. And when there's a mutation in the estrogen receptor, the tumor is estrogen independent. That switch, which was dependent on estrogen, is constantly on. So you can bring the estrogen levels to very low or even zero. The tumor is estrogen independent and continues to grow, but it's still ER dependent. So drugs like aromatase inhibitors don't work in that setting because they work by lowering estrogen. But drugs that directly bind to ER, like elacestrant, would work. And that's why this was an important setting where this drug was developed.
As Dr. Bardia mentioned, the ESR1 gene mutation is something that you acquired during treatment with aromatase inhibitors, which means that it's not something that you're born with, like a mutation to the BRCA1 or 2 gene. We asked Dr. McDonnell to explain the difference.
For the most part, when we talk about a patient with a BRCA mutation, we're talking about somebody who has a genetic mutation. That is that they were born with this mutation and they are predisposed because of that mutation to develop cancer. That's basically what BRCA is. Now, there are some tumors that can evolve to also acquire BRCA mutations, but they're not the ones we're focused on when we talk about BRCA mutant patients. But the ESR1 mutations are different. You're not born with those mutations. These mutations are somatic and they occur only within the tumor. And they occur only in the tumor where that tumor has been put under phenomenal selective pressure. So let me give you an example. The breast tumor, the estrogen receptor positive breast tumor really wants to use the estrogen receptor signaling pathway. It's learned how to do it and it wants to do it. And then we come along with an aromatase inhibitor and we take away the gas, take away the thing that it wants. Well, it says, well, I'm so addicted to the estrogen receptor signaling pathway, I'm going to figure out another way to turn that on. And so what happens is there are mutations that occur in every cell every day that die away because there's no selective pressure for them. But now, when you take away you add the aromatase inhibitor and you take away the estrogen, suddenly there's a selective pressure for these and they grow out. So that's what you're talking about, evolution, an evolution of the tumor. Whereas in the BRCA, it's not. You're just born with that.
You might be wondering, how would I know if my breast cancer has an ESR1 mutation? Well, the good news is ESR1 gene mutations are extremely rare in early breast cancer. Dr. Bardia explained to us how ESR1 gene mutations are detected, which uses a blood test called a liquid biopsy.
In terms of how to test, because it's an acquired mutation, if you test the primary tumor, you would not detect ESR1 mutation. It's something that's usually detected by a blood test. So when a patient has disease progression on AI CDK4/6 inhibitor, at that time, if you do a blood test and do plasma-based genotyping, that's how ESR1 mutations are detected.
We've heard that not only can your tumor change during treatment, but your treatment, like the CDK4/6 inhibitors Dr. Bardia mentioned, can also influence how well you respond to subsequent drugs. Further analyses from the EMERALD trial found that the length of first-line CDK4/6 inhibitor treatment was associated with better response to elacestrant. While progression-free survival improved with duration of CDK4/6 inhibitor treatment with elacestrant, there was no difference with those who received the standard of care. Dr. Bardia also shared that a single test may not be enough to detect an ESR1 mutation during treatment. We asked him about when patients should ask their doctors about being tested for an ESR1 gene mutation.
After the first-line setting. So after disease progression and first-line therapy, it should be considered. And then something that, cost issue aside, if feasible, should be done serially because it can increase over time. So even if the first test doesn't show, does not mean that the next test would not show it.